We're talking here about severe childhood trauma. What were some of the things you were seeing come through your office as a pediatrician?
Well, I came to this work when I finished my residency at Stanford in 2005, and I opened a clinic for California Pacific Medical Center called the Bayview Child Health Center. And our goal was to reduce health disparities. So our focus was on improving health outcomes in a neighborhood that had some of the worst health outcomes in the city of San Francisco. So just to, as a benchmark for folks, a child born in Bayview, Hunters Point, has a life expectancy that is 11 years shorter than a child born in Russian Hill. And for myself as a doctor, I thought this is utterly ridiculous. So we opened a clinic and just implemented clinical protocols to improve some of the basic health outcomes. But as you mentioned, Willie, what I was seeing over and over again was that these kids were being referred to me for ADHD, or attention deficit hyperactivity disorder. But when I sat down and I did a history and physical exam, like that's our job, they teach you that, medical school day one, what I found was that I could not make a diagnosis of ADHD because for most of the kids, they had such severe histories of adversity, witnessing shootings in the community, witnessing parents who were substance dependent or mentally ill, growing up in households where there was just so much drama going on that as a doctor, it felt like there was something that I was missing.
So I think most people came at this before you got on board, and we'll talk about this study as well, as a social problem. You had a tough childhood, life is hard, sure, you had some problems down the road, but you're coming at this as a physiological problem, that there's a connection between their childhood and illnesses they're suffering from later on. And you should talk a little bit about the adverse childhood experiences study that sort of lit the fuse for you.
Yeah, that is to say the least. So in 2008, after seeing, kid after kid after kid after kid after kid who's being sent to me for ADHD, or honestly seeing patients who had, weird autoimmune diseases, right? Or seeing this extraordinarily high rate of asthma, and asking myself, what the heck is going on here? And then my colleague walked into my office and he said, "Hey, Dr. Burke, have you seen this?" And in his hand was a copy of the study called the Adverse Childhood Experiences Study. And literally, like, the top blew off of my head, right? I'll just say that, because this study was a study that was done by Kaiser Permanente and the Centers for Disease Control and Prevention. And what they did was they asked 17,500 adults about their histories of something called adverse childhood experiences. And those include physical, emotional, or sexual abuse, physical or emotional neglect, a parent who had mental illness, substance dependent, so growing up in a household where someone had mental illness, substance dependent, incarceration, where your parents were separated or divorced, or where there was domestic violence, right? And what they found was mind-blowing. Two things. Number one, ACEs are incredibly common. So
adverse childhood experiences.
Yes, adverse childhood experiences that we now call ACEs. 67% of the population had at least one of these experiences, and 12.6%, so 1 in 8 individuals, had 4 or more of these ACEs. But if you had 4 or more of these ACEs, the other thing that they found was that there was a dose-response relationship between early adversity and health outcomes, right? And I just want to kind of lay this on the audience for a second. If you have 4 or more of these ACEs, your relative risk of ischemic heart disease, #1 killer in the United States of America, is 220%, right? For stroke, it's 190%. For chronic obstructive pulmonary disease, it's 390%. For depression, it's 460%. For suicidality, it's 1,220%. And when I read that data, I'll be honest, I was pissed. Because I did my residency at Stanford, And no one ever taught me this information, and yet I was seeing child after child after child coming through my door with extremely high ACE scores, and I was never given the training in medical school or residency to say, okay, here is what we do about this.
And that study came out in 98,
Yes.
is that right? So why has it taken it so long? If that study was such a revelation to you, why wasn't it a revelation to more people? Why didn't the world hear about this?
So that's a really good question, one I've asked myself many times. And I think there are a couple things. Number one, as we heard Eric mention before, oftentimes there's a couple decades between the time that something is discovered and the time that it gets put into routine practice. But the reality is, we doctors are not super great at communicating this information sometimes. And the two principal investigators on that study, and there have been many, 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 many studies, hundreds of studies that have come out subsequently to corroborate these scientific connections. I love these two guys who are the principal investigators, but if you hear them talk about it, they sit there and they do their PowerPoint, and they talk about, okay, relative risk of disease and da-da-da-da. And they think that the data, just in and of itself, is going to compel people to do something. And I disagree. I believe that we have to compel people to do something. I believe that we have to, when we look at this information, in addition to shouting it from the rooftops and letting folks know what a major health threat this is, we also have to lay down a path for folks to follow to say, this is a public health crisis, and this is what we can do about it.
What's really interesting about this, too, is the way it cuts across socioeconomics, it cuts across race. You work in Bayview, primarily African-American, a lot of kids in poverty. But we were talking last night, you could be living in an upper middle-class suburb, and your father was an alcoholic in the home and see some of these same problems.
Well, that's exactly right. In fact, part of the reason that that this study has been so compelling is because when you hear about the data, many people, especially when they hear me talk about it, they think, oh, it's probably her population. And the study was done, A, in Kaiser, everybody's got great health care. B, the study population was 70% Caucasian, 70% college educated, right? This is not a matter of those people in those communities that are so disadvantaged. It's actually a matter of the simple biology of how our bodies respond to adversity, right? You're walking in the forest, you see a bear, your body activates your fight or flight response. It's called your hypothalamic pituitary adrenal axis. And so your adrenal gland down here gets activated, and it sends out a ton of stress hormones, adrenaline and cortisol. And they have a job to do. They increase your heart rate, they dilate your blood vessels, they dilate your pupils, right? So that you can be ready to either fight the bear or run from the bear. That is the biological response, and it's adaptive. But the problem is what happens where you're in a situation where that bear comes home every night, right? Or that bear is waiting for you when you walk out on the street and you're going to the bus stop, right? That process is activated over and over and over and over again, and in some cases hundreds of times a day. And it goes from being adaptive or life-saving to maladaptive or health-damaging. And that is what doctors are now calling this thing called the toxic stress response, which leads to long-term changes in cognitive function, as well as changes to your immune system, your hormonal systems, and even the way your DNA is read and transcribed. And that's the reason that we see, for folks who have 7 or more adverse childhood experiences, that they have triple the lifetime risk of lung cancer and 3.5 times the risk of ischemic heart disease #1 killer in the United States of America.
So as a pediatrician, how does this change the way we screen kids? When they come into your office for a regular checkup, what are you doing that you didn't do before you knew this?
Well, so here's the thing, right? So we have this huge public health crisis, right? 4 more ACEs, doubles or more your risk for 7 out of 10 leading causes of death in the United States. And folks say, well, what can we do about it? Well, I did my public health degree at Harvard, and one of the things that they teach you is basic public health 101. How about routine screening and early intervention? You can wait till someone gets to stage 4 cancer and then try to throw the kitchen sink at them, but they will have the treatment will be more expensive, it will need to be more intensive, and it's less likely to be successful, right? So what do we do with cancer? We screen for it early. We do routine screenings, right? With adversity, you can wait until kids are being booted out of school for their bad behavior, they're being suspended or expelled. You can wait until they've got terrible asthma or worse, or you can start like we do at our center, where we start in infancy. We screen for adverse childhood experiences as part of every well child check because I know that if the parent fills out the form and that number is 4, right, that child, their relative risk they have double the lifetime risk of asthma. They have 220% as likely to develop ischemic heart disease. They're 4 times as likely to be depressed. And by the way, based on our data, their risk of having learning and behavioral problems in school is 32.6 times that of my patient with 0 adverse childhood experiences.
So you can do what you do on your side. You can intervene early, but if you can't take that trauma out of the kid's house, is it an uphill battle for you? In other words, you're not going in the home and taking that extreme trauma away.
Well, I'll tell you what we see. So #1, we start with, so we have a research department. Our center is built around 3 pillars: our clinical work, our research work, and our field building and advocacy work. And what our research work does is scour all the literature to figure out, okay, what the heck are the best practices here? What is evidence-based and what can we do? And some of the most evidence-based practices include things like home visiting. So we have nurses and case managers that go and do home visiting. And step 1 is reducing the dose of adversity. Just like secondhand smoke or lead poisoning or anything else, if you have a kid, and I'll give a great example. I had a kid who was an 8-year-old boy who had a very high ACE score, right? But when you dive in, it turns out that his mom, her situation was 10 times worse, right? She pretty much went through hell. And she's doing the best that she can, and she recognizes that there are challenges in their household, but she's trying to do right by her child, and he's better off than she was when she was a child, right? So what we do in that situation is go in and be able to support and scaffold the family with 2-generation approaches. We cannot begin to think that we're going to just treat the child, and we're not going to address the fact that the caregiver themselves has had some of those experiences. And so for our 0 to 5-year-olds, we do parent-child psychotherapy, where the therapist works with both the parent and the child to figure out how the parent's history of adversity may be affecting the way they're raising their child.
Are you seeing traction on this? You've been a very visible face for this. You're getting the word out as much as you can. That your TED Talk was viewed like 3 million times or something like that. Are you hearing other pediatricians across the country pick up on this?
Well, one of the things I'm really, so yes, we are seeing traction, but not nearly as quickly as I would like to see. Because folks are still very hesitant to change practice, right? Trying to get, especially doctors, to change practice is a really big challenge. But one thing that I will say is that on Friday, I'll be flying to DC to give the keynote at the first day of the National Conference of the American Academy of Pediatrics. And they're going to be having, for the first time, a whole day dedicated to adverse childhood experiences and toxic stress. And in fact, earlier this year in July, they had their the first singular conference on the issue of toxic stress that was kicked off in San Francisco, and where they asked me to come and speak. So again, we're starting to see traction, but there's so much more that needs to be done.
I can imagine some pediatricians would listen to you and think, my job is to take care of the child, but not to go into the home, the way you've taken it to the next level, and deal with whatever's happening in that family. That's a social worker, that's someone else. Mm-hmm. How do you answer that?
Yeah, so and what we're trying to do is we are not trying to get doctors to become therapists or social workers or anything else. But guess what? I'm not a cardiologist. I'm a general pediatrician. That doesn't mean I don't take my stethoscope and lay it on the chest and say, okay, I hear a murmur. I'm going to refer you to the cardiologist. That's what my job is as a general pediatrician, is to say, can I assess the general health of this patient, and are they at risk for something bad? And if they are, I need to refer them on to the right person, whether that person is a cardiologist or a pulmonologist or a geneticist, or in this case, a multidisciplinary team that can address adverse childhood experiences. Now, what I experienced from my practice was that there was no place for me to refer these kids, because there is no medical specialist whose job it is to deal with the biological consequences of adversity. And so we created that in our center. But what general pediatricians can do is, this is one of the part of the work that we're doing actually, is coming up with recommendations about what general pediatricians can do. So we say, screened, this is what you have to manage in your own practice, and the rest of it, you can refer it out.
As you pointed out, the research is relatively new on this, so you don't have a lot of data to work on, but are you starting to see evidence that this works, intervening on these kids?
Oh, without a doubt. Yeah, absolutely. I think that we are seeing, the big thing that we are seeing in our practice is on a day-to-day level, we are seeing improvements in the health and the outcomes of our patients, right? And so that's really exciting. One of the things that we're hoping to do is track that in a more systematic way. So we just got an investment to do a 3-year randomized controlled trial in partnership with UCSF and Children's Hospital Oakland that we're really excited about, because that's what we need. We need the scientific rigor to demonstrate that the improvements that we're seeing in our center are replicable and scalable in a larger way.
Okay, so we're trying to get the word out about this. You've got a room full of influencers here. As they leave, what would you ask them to do? Besides tweet out your TED Talk.
That would be fantastic. No, I think there is a lot that every single person in this room can do. I think that if there are a lot of folks in here who are investing in science and technology, and this work has been made possible by dramatic advances in science and technology, right? We now have the ability to measure the impact on the developing brain and on the genome, for example. And so I would ask folks who are investing in technology, keep this in mind. I had a conversation with a gentleman who runs the National Institutes of Health, the section that focus on children. And I was saying, hey, you all at the NIH, all I ask is that you begin collecting data on adverse childhood experiences as you fund research on cancer or on Alzheimer's. Collect it as part of your demographic data. And for those who are in this room who are working in advances in technology, for example, data collection and analysis is something that we need a lot of support with in being able to move this forward, particularly on a public health level. I mean, if you run a philanthropy, invest in this work. If you are interested in education or if you're doing work with schools, make sure that the schools that you are working with or investing in are not using putative school discipline that exacerbates the situation by further inflaming the dysregulated stress response, right? But that they're informed by the best practices of the latest science that's coming out. And if you're none of those things, the one thing that we know for a child who's exposed to high doses of adversity, the biggest remedy is a caring, self-regulated adult. So if you have the opportunity to cultivate a relationship and be that buffer for even if it's one child, you will have done something great.
Well, if the original authors of that study were not great at communicating the message on this public health crisis, you are the opposite of that. Congratulations.
Thank you so much.
Thank you.
Thank you.